Welcome to Pediheart, Pediatric Cardiology Today. My name is Dr. Robert Pass, and I'm the host of this podcast. I am Professor of Pediatrics at the Icahn School of Medicine at Mount Sinai. Thank you very much for joining me for this 310th episode of the podcast. Before we get into this week's episode, I wanted to address something I learned this past week, which involves the so-called PediheartNet list server. Some have had the mistaken impression that this podcast, called Pediheart, because of its name, is affiliated in some manner with that Google list. It is not. In fact, to prove this point, this past week I learned that some who have received my bi-weekly messages about the podcast episodes that are about to come out have flagged my email announcements as spam. As a result, Google has blocked me from posting anything about the podcast on that forum. For this reason, you won't any longer be seeing any more announcements about the podcast there. Of course, most of you know that I place announcements in multiple areas of the internet every week and on social media such as Instagram, Facebook, Twitter, LinkedIn, and Threads. But if you happen to be in the minority of people who are getting information regarding the podcast exclusively there, I would instead ask that you just follow me on any of those other social media venues for information regarding the upcoming episodes. And thank you so much, as always, for listening. I hope everybody last week enjoyed our episode with surgical pioneer John Brown of Riley Hospital for Children in Indianapolis, Indiana. For those of you interested in the history of pediatric cardiovascular science, and specifically cardiovascular surgery, I'd recommend you take a listen to Dr. Brown in last week's 309th episode. As I say most weeks, if you'd like to get in touch with me, my email is easy to remember. It's pediheart@gmail.com. This week we move into the world of diversity in the workplace of pediatric cardiology. The title of the work we'll be reviewing is The Heart of the Matter, A Path to Building Diversity in Pediatric Cardiology. The first author of this work is Ogochuckwu Cox and the senior author Brittany Hills, and the authors come from multiple centers. Dr. Cox is a pediatric cardiology fellow in the Division of Pediatric Cardiology at CS Mott Children's Hospital at the University of Michigan. When we're done reviewing the paper, Dr. Cox has graciously agreed to speak with us about it. Therefore, let's learn a little bit about this essay and then speak with one of its authors. This week's work is not really a research paper, but is instead an essay on the impact of underrepresentation in medical training, with a focus on pediatric cardiology. The work begins with a number of comments regarding the dearth of Black or Hispanic pediatric cardiology trainees, and they reference the December 2020 numbers, where there were 445 total fellows in pediatric cardiology training, with only 14 identifying as Black and 37 as Hispanic. In other words, the authors explain that Black fellows represented only slightly more than 3%, or to use their terminology, a sliver of the pie. They start by reminding us of the definition of underrepresented in medicine groups, which are defined as Black, Native American, or Hispanic people, and also reminding how their numbers in medicine do not reflect their numbers in the general population, though they do mention that there are rising numbers of these candidates in medical school. The reason for these numbers rising are increases in summer programs during undergraduate years which facilitate mentorship, as well as preparation for pre-med students. They explain that these efforts to enhance Black, Native American, and Hispanic physician enrollment is based on healthcare disparity research, showing that putting underrepresented in medicine doctors in the community will improve patient-centered care. They explain how graduate medical programs are now supporting more diverse candidates by building inclusive residencies for these candidates to thrive, and they explain how in pediatrics our goal should be attaining a diversity of the workforce that mirrors our patient groups. The authors then point to some literature suggesting better outcomes for patients in general pediatrics when there is racial concordance between physician and their patient, and they posit that the same should be true for pediatric cardiology. They explain that the most likely explanation for these outcomes with racial concordance is related to improvements in communication, and explain how communication is a key driver in patient-family buy-in regarding pre- and post-operative management of congenital heart patients, underscoring why anything that can improve communication could potentially result in better outcomes. The authors then review the financial factors that negatively impact people choosing to enter pediatrics, which we're all aware of, with the low pay being a major concern, where pediatrician salaries in the United States can be literally 1/2 to 1/3 of starting salaries in other fields of medicine. Given the $200,000 average student loan debt that med students in the United States take on, and lower income backgrounds of Black, Hispanic, and Native American families, and this gap between debt and income becomes even more daunting. They then delve into the notion of social determinants of health on congenital heart disease outcomes, and reference Dr. Kayla Lopez's work on this, demonstrating significant postoperative mortality disparities between non-Hispanic white and non-Hispanic black children from 2020, and which we reviewed with Dr. Lopez some years back. They emphasize how there were higher mortality rates amongst black and indigenous populations, and how these disparities do not appear related just to access to care or socioeconomic status. And they reference other works on health communication improvements having potential to reduce disparities, and the authors suggest that this literature supports the improvements in communication that may arise from race concordance between doctor and patient. They reference how concordance between the race of the provider and the patient may result in more culturally centered care, and will improve communication and help uncover social factors that may be affecting health of a child with congenital heart disease that would not otherwise be easily determined. And so the authors then ask the question, how can representation be improved in pediatric cardiology? They break it into 4 categories, and I'm going to ask Dr. Cox to review these in greater detail in our interview, but I'll very briefly explain what they are. First, there's reflection, which they describe as an examination of applicant pools and the matriculants of given programs over the last, say, 5 years, and looking for trends and backgrounds within the program culture. They make special reference to the notion of not emphasizing board scoring as much, given the manner in which these scores may reflect, at least partially, socioeconomic and racial class differences, rather than aptitude. Second is that of fostering, which involves engaging residents and minoritized populations in cardiology and providing resources to help with fellowship navigation. They offer the American College of Cardiology's initiative in cardiology amongst Black, Hispanic, and Native American physicians to foster an interest in cardiology early during internal medicine residency. Third, they speak of prioritization, explaining that all of the decisions should not be made just on good fit qualities, but instead qualities like empathy, emotional intelligence, cultural situational awareness, and tactfulness, which are similarly critical. And they speak also of how underrepresented in medicine physicians should be encouraged to perform disparity research if they wish to, and how it ought not to be undervalued scientifically. Finally, they speak of mentorship in which talents of the underrepresented fellows and residents are identified and cultivated as their strengths are supported by faculty. The work ends with some comments by the authors about the daunting feeling of presenting to a group of colleagues where no one's face in the audience looks like yours. They speak of wondering if they would fit in because of the lack of diversity in many programs, and speak of how important it was for mentors to provide for them confidence to proceed with the application process and then grueling fellowships. And they conclude by saying, quote, "The decision to pursue any specialty is heavily influenced by an individual's exposure to the field and the sense of belonging that they may experience. We must create a community that attracts those who best represent the faces of our patients." Well, this is certainly an interesting and insightful work addressing the lack of diversity in pediatric cardiology, but subspecialty training in general. The many ways in which a more diverse workforce will improve outcomes seems unassailable at this time, and really it seems the only remaining important questions are how we can achieve the goal of improving our cardiology provider diversity. I think that the authors provide for us a very nice framework to think about things, and it seems clear that providing mentors and support along the way was very important for these authors. I think it'll be useful to hear Dr. Cox explain to us better the 4 pillars upon which they feel representation can be improved, and also what sort of efforts they're making in their own training programs right now. In the interest of time, therefore, let's move on to speak with Dr. Cox. Ogie Cox is a graduate of Binghamton University for college. After that, she worked as a research assistant at Memorial Sloan Kettering, where she received a great deal of mentorship, fostering her own interest in pursuing medicine. She studied medicine at SUNY Upstate for medical school. Following this, she went on to perform her residency in pediatrics at Lurie Children's Hospital in Chicago, followed by University of Michigan, where she is now a third-year fellow in cardiology with a great interest in cardio-oncology, cardiomyopathy, and heart failure and transplant, and also health equity. It is a delight to welcome an up-and-coming superstar to Pediheart. Welcome, Dr. Cox, to Pediheart. I'm here now with Dr. Ogie Cox. Dr. Cox, thank you very much for joining us this week on the podcast.
Hi, thank you so much for inviting me. I'm really excited to be here.
I'm excited to have you. Thank you. Before we get going, Dr. Cox, one of the things I was wondering is what motivated you and your co-authors to pen this essay on this very important topic now?
Absolutely. So From a personal perspective, the article, The Heart of the Matter, A Path to Building Diversity in Pediatric Cardiology, really stemmed from my experience going through the application process for fellowship. And I felt very introspective in my early first year after the match, and in just talking with my co-authors and my colleagues now, we just felt that there was some responsibility associated with it being part of that small percentage of Black or African American fellows. We wanted to provide some guidance for something that in the medical community is largely understood to be a problem. And there are a lot of articles that sort of delineate all of the issues associated with some of the topics we discussed in the article, including race concordance in between patients and physicians. And so we wanted to provide some steps to really try to manage this situation. And that was the impetus for the article. I felt like we needed to provide some kind of guidance instead of just kind of discussing what the problem was.
Well, you certainly did that and achieved your goal for sure. You mentioned the vital role that good communication provides in outcomes and care in general, and it seems like virtually every podcast that I do, something about communication proves to be very important. And you speak also about the evidence that race concordance between the patient and the caregiver can improve communication. I'm wondering if you might be able to sort of flesh that out for us a little bit, what the evidence is for this. And although we are making efforts to improve representation by underrepresented trainees, and we're working on that, I think we can both agree it's going to take a little bit of time. And in the interim, I'm wondering if you might be able to offer some suggestions for physicians or providers who are not from underrepresented groups, how they could better communicate to try and bridge that gap with their patients, and what resources we might be able to use to help.
Yes, absolutely. I can talk a little bit more about that. And a few of the things that have been discussed in previous articles, whether by op-ed or really just investigating sort of mortality outcomes, have shown that the inclusion of race concordance in a situation does help to build alliances between the patient and the physician. And it overall helps to realize these optimal health goals that we like to have for our patients. But largely, they really help to open the door to discussion about the barriers to health management at home, and discussions about supports for cultural practices or improving care overall from a family's perspective. And the goal for communication really should be always to, identify what barriers are potentially impacting the family's care, and really be patient-centered, provide information that's well understood, and that helps with that partnership building and patient engagement that we really want. And it often seems that the goals may not be aligned at the time that you have these breakdowns and adherence, and it seems like the goals aren't aligned. But sometimes it is because of, communication that did not achieve that optimal goal of, everyone being on the same page. And yes, there's a lot of data to show that there is improvement in patient satisfaction, and this intention to adhere and trust with the race concordance. And while that's continued to be worked on, as you mentioned, I think engaging other team members in those discussions with families, from social workers, nurses, other members of the staff who contribute to the care of the patient. And oftentimes, as someone who is from an underrepresented community in medicine, I do find other people who are not necessarily physicians but share the same geographical ancestry or background as I do, that I communicate with in the hospital. And I do feel that families may benefit from having that in those teams. And I think sometimes we forget how important some of those interactions may be with families. And it may be that person who's not maybe providing direct clinical care, but maybe offer a different perspective and reach the family. So I think in the interim, while working on improving the overall demographics of the medical team, the direct clinical team, really including the other members of the team in discussions And then also the next thing I would mention is maybe over communicating.
Yeah.
And then, as a trainee, this is helpful for me when as in going through now as a third year. Over communication has been really important to help my attendings trust me. They understand where I'm like where I am, and I kind of can run ideas by them. And I think over communicating with patients sometimes may help identify any barriers may have been missed in initial assessments, and may really help the family understand that yes, the goal is to their benefit.
Yeah.
I think those would be the two recommendations I have.
Yeah. I mean, I think over communication is definitely a central feature of quality improvement efforts, right? And so I think that rings really true. Thank you for that answer.
Of course.
Ogie, I'm wondering if maybe for those in the audience, I summarized your paper as I do every week, but I would rather hear it from the author. If maybe you could briefly summarize for the audience the 4 pillars that you and your co-authors felt represented areas for improvement, namely reflection, fostering, prioritization, and mentorship.
Yes, absolutely. So overall, our essay is discussing the impact of underrepresentation in medicine, in medical training, with this focus in pediatric cardiology. And like I said, we wanted to have some goals to work towards, or some guidelines for institutions to start practicing. And the first step we thought about was reflection. Really, in every program, there are generally trends that can be identified, whether they're in gender or geography, background, interest that the previous candidates have had. And sometimes it may be helpful to include someone who's not part of the initial team that draws these applicants in to go run through these reviews, and understanding what the trends are may help clarify whether or not an institution is meeting the goals of their entire recruitment campaign. Yeah. And so if in assessing these trends, everyone feels comfortable that yes, we are achieving our goals in terms of diversity, in terms of equity, then that's obviously perfect and optimal. But if it turns out that there are some changes that could be made to help better the team, that's one of the ways that could be used to identify that.
Yes.
The next I know we talk about was fostering, and really the goal is to engage residents who are in these underrepresented in medicine populations and provide resources for navigating fellowship. And this ties really into mentorship, which is one of the last steps we talk about. And the idea is that if you have a candidate who may be interested in this process, really identifying them earlier and providing supports to help engage them through the years of residency and into fellowship. And then, if they choose to go to fellowship, really supporting them in their growth through navigating that process of fellowship. And that also goes into identifying what we're prioritizing in the recruitment. In that, I know you talk about this a little bit more in the essay, and really focusing on residents who may be already engaging in this kind of work, where they're identifying psychosocial stressors towards patients, understanding the role of social determinants of health in patient outcomes, and really prioritizing this work, knowing that these candidates, these residents, trainees have these skills and they have the medical knowledge to meet the rigors of fellowship, but they also bring with them this unique perspective of understanding the problems that patients may themselves be facing, or really having shown an interest in both investigating problems patients are facing and also identifying potential solutions to them. I think that's really helpful when you have people who are aligned to those goals, if you're including them in the team. And they don't necessarily need to be from the backgrounds that are impacted by a lot of these social determinants of health, but they've shown consistent interest in really addressing these problems, I think is important. Yeah. And then finally, I think mentorship speaks for itself. We all understand the role of mentorship in just career trajectories, but really cultivating talents and identifying trainee strengths, supporting their leadership goals and their aspirations, and really sponsorship as they work through their careers is key. And this kind of leads to what was going to be our next steps for this project.
Yes.
Going forward.
Yeah, please go ahead, Ogi. Why don't you share that with the audience? What are your next steps in this? And I was wondering also, what are you doing in your own program to foster this, the concepts that you espouse in your essay?
Absolutely. So one of our next steps is really to identify whether or not a lot of these items that we're listing are priorities for fellows. And we're doing this by a survey that we've developed that really is the goal of the survey is to kind of describe the mentorship experiences of residents who have gone into fellowship. And really in that understanding how key was mentorship towards their decision to go to fellowship. Additionally, we want to identify the sort of the perception of the culture of pediatric subspecialties, including pediatric cardiology, what the role of the availability of those subspecialties at their home program was, and the financial constraints of pursuing further training post residency. So we've developed a survey, and it's close to being launched. We'll probably be sending it out in the fall to trainees, and the goal is to really get a better sense of from those people who have gone through the process how these factors, mentorship, financial constraints, sponsorship, the sort of idea of fit and the perception of the culture within those programs, how did those impact the decision to go into fellowship. And depending on those results, that might actually help change our practices in terms of recruitment. We have so currently at University of Michigan, and we've had a lot of discussions within our program about understanding, what are the trends in our recruitment, and what are our goals as an institution, as a program, what are we working towards? And I think there have been changes over the years in terms of trends of the applicants that we're getting, the sort of review and how holistic it is and who is included in that review of applicants, and who the applicants are meeting, what is being highlighted in the program. And I think that has had a positive impact. I'm sure my program directors are working on sort of the data for this, but I think it has had a positive impact in who we've been able to help train in our program.
And Ogi, are you talking about all subspecialties within pediatrics or explicitly pediatric cardiology?
So the first survey is going to go out to just pediatric cardiology, and then the subsequent survey is going to be through all pediatric subspecialties. And in that, we are actually hoping to invite respondents to be involved in a more in-depth interview where we discuss some of these topics, things that may not have, the nuance they have been missing from the survey. And we will be planning to compensate for this interview portion, and we'll be offering a raffle for the initial survey.
I was wondering, Ogi, when you guys were writing this paper, did you find that there was a difference of opinion in regards to the experiences that you had all had as underrepresented physicians, or were they shockingly similar?
I would say that overall there have been a lot more similarities than differences. I think we have we are all at different institutions, and we've followed different paths in order to get to where we are, and have had different experiences, positive and negative. And I think that's shaped, our career trajectories. But there are certain things that we find some commonality in, and just in talking to other trainees, not just in pediatric cardiology, who are underrepresented in medicine, there's been similarities in that experience. And just in sharing this essay with people who are not in pediatric cardiology, there has been a lot of sort of understanding that, yes, this is not a problem that is unique to pediatric cardiology. It is certainly something that, is being addressed and discussed in a lot of other fields. And I know in the paper we focused on the total numbers of fellows and trainees over the course of years and pediatric cardiology, but it's not significantly different when you look at the other subspecialties in pediatrics.
Sure, of course. Well, for those in the audience, it's late on Monday night. Dr. Cox was nice enough to speak with me tonight, and I'm going to finish the interview at this point. And I want to thank you, Ogie, very much for highlighting what is obviously a very important, critical topic that is not adequately addressed in our literature thus far. But this paper certainly goes a long way to pushing us in that direction. Congratulations to you and all of your co-authors, and I look forward to hearing about the results of the study that you just described for us. Thank you and congratulations.
Thank you so much. It was really great to be on the podcast.
Great pleasure. Thank you. Well, once again, as I'm apt to say, when the guest is good, there's not a whole lot to add. Dr. Cox shared her rationale for the essay that she wrote and also offered for us many examples regarding some of the important reasons that racial concordance that can come from improvements in diversity in our workforce can drive improved communication and outcomes. I also thought that she provided for us a very nice framework for all of us to think about how to achieve the goals for better representation in our field. I am most appreciative to her for taking time out as a busy third-year fellow at an excellent program to speak with us, and hope you enjoyed her comments as much as I did. This past week, many of you may have heard the sad news of the passing of Dr. Connie Hayes at the age of 87. Dr. Hayes was Emeritus Professor of Pediatrics at Columbia University and was a cardiologist on staff for well over 40 years. She had many roles in the division, and some may recall our conversation just a few years ago with Dr. Peter Lang, in which she explained how Dr. Hayes was an inspiration for him in the arena of cardiac critical care. For most cardiology fellows and cardiologists at New York Presbyterian in the past 25 years, she was perhaps more well known in her role running the cardiology outpatient clinic and teaching cardiology fellows. She was a wonderful person who was beloved by all who were privileged to know her, and I am certain that I speak for many in my region in expressing our profound gratitude to her for her kindness and collegiality, and our sincerest condolences to the family. To conclude this 310th episode and to honor Dr. Hayes, we end with the lovely Negro spiritual Ain't That Good News, composed by William Dawson, and sung winningly by the American soprano Kathleen Battle in a live performance from nearly 40 years ago. Thank you very much for joining the podcast this week. I hope you all have a good week ahead.
I got a crown up in that kingdom, ain't that good news? I got a crown up in that kingdom, ain't that good news? I'm gonna live on this world, gonna shoulder up my cross, gonna take it home to my Jesus, ain't that good news? I got a robe up in that kingdom, ain't that good news? I got a robe up in that kingdom, ain't that good news? I'm gonna live on this world, gonna shoulder up my cross, gonna take it home to my Jesus, ain't that good news? I got a home up in that kingdom. I got a home up in that kingdom. I'm gonna live on this world, shoulder up my cross, take it home to Jesus. Take it home to my Jesus. Take it home to Jesus. Ain't that good news?